All right. I just want to thank everyone for attending today. We're going to be talking about health insurance and open enrollment. Now is a really important time of the year, so this is a great time to brush up on some of these different health insurance options that exist and some of the protections that exist as well. My name is Connor Hannigan. I'm an attorney at the Cancer Legal Resource Center. We'll talk a little bit about our organization and what we do, and then we'll go into the presentation. So first off, what is the CLRC? The CLRC stands for the Cancer Legal Resource Center. We're a program of the Disability Rights Legal Center. The CLRC provides information and resources to people affected by cancer, including patients, survivors, caregivers, and healthcare professionals. All of our resources are free regardless of income. And people often ask, what does cancer have to do with the law? So this is a list of some of the cancer-related legal issues that come up. Cancer affects, as you probably know, the patient, the survivor or thriver, families, healthcare professionals, and it also impacts many different areas of the law. So if someone has a legal question and they are affected by cancer, whether or not the topic is listed here, they can contact the CLRC for more information. We operate a national telephone assistance line. People can call in, ask a legal question, and we'll do our best to research and answer it for them. Here's some of the free national resources that we have. So if you'd like to view any of those resources on a number of topics related to cancer, you can just visit our website. Educational webinars like this one are recorded, so we can later put them on a YouTube channel for you to share with anyone who you think may want to learn about a variety of subjects that we talk about. If you have questions about today's presentation, you can type them in the chat box. And we will leave some time at the end to try to get to those. If you have specific questions about your situation or someone that you know has a question that you want to ask about anything specific, then you can fill out an online intake form at clrcintake.org, and we will do some direct research for you and then customize some local resources for you and research the state laws that would be applicable to where you're located. Everything is confidential. We've also recently developed a revised version of the Patient Legal Handbook with the generous support of the American Cancer Society and Breakaway from Cancer. This handbook provides an introduction to the most common legal issues that a patient diagnosed with cancer is likely to face. It's available to download for free online in English or Spanish by going to our website, cancerlegalresources.org. If you are a provider, you can request printed copies shipped to your office or hospital. So this webinar is going to give an overview of insurance basics. We're going to discuss some current insurance options, some consumer protections, and ways to maintain or change coverage, whether you're shopping on or off the health insurance marketplace. So I want to quickly go through some insurance basics with you so that if you're looking to purchase new insurance, you're familiar with the terms that you'll be seeing. And I know that some of this is going to be pretty straightforward and that a lot of you are very knowledgeable when it comes to your health insurance, but I just want to make sure that everyone is on the same page. So the first thing to remember is that it's the patient's responsibility to understand their coverage and limitations. Saying, I didn't know that was covered, usually does not work as a way to get out of a medical bill. Even when we call our insurance company, there's a recording that probably says that the verification of benefits is not a guarantee of coverage or something to that effect. So we can't even always rely on the actual physicians treating us to know what's covered by our insurance plans and what isn't, or to what extent. Even if your provider's office says they'll call the insurance company to find out or tells you something's covered, it's always a good idea to become familiar with your plan so that you understand copays, deductibles, and networks to help prevent unforeseen costs. So in part one, we're going to go over some of the basic information everyone should know and understand about insurance. Knowing your insurance company name, for example, that is Blue Shield is not enough. So if you call a doctor's office to make an initial appointment, they'll ask whether it's private insurance because Blue Shield is also a Medicare and Medicaid provider in some states, and not all doctors accept all insurance plans. Private insurance is one you buy as an individual or family or get through your employer. Medicaid is insurance for people who are low income and meet other requirements. If you receive supplemental security income, known as SSI, you should be eligible for Medicaid. Medicare is insurance for people who have been receiving Social Security Disability Income, or SSDI, for 2 years or 65 or older. Private insurance, as well as Medicare Advantage or Medicaid plans, can all be managed care plans. Those are things such as HMOs, PPOs, and POS plans. HMO stands for Health Maintenance Organization. HMOs usually have limited choices for their members because members have to select doctors and hospitals from within a participating medical group, which is why they're typically less expensive than a PPO. There are two types of HMOs. The first is where physicians practice in their own offices and belong to medical groups. Those are called an Independent Physician Association, or an IPA. Some examples of these are Blue Cross and Aetna. Second type is a standalone facility, and that's when an insurance company hospital that you visit has all of your needs in one place, and the most well-known of these is Kaiser. PPO stands for Preferred Provider Organization, and here the network of providers is less limited than HMOs, and physicians are reimbursed at higher rates for services provided, but PPOs are usually more expensive than HMOs. POS stands for Point of Service. These plans combine aspects of HMO and PPO plans, where you have to get a primary care physician to make specialist referrals like an HMO. Users usually have some freedom of choice in providers, even out of network like a PPO, but with greater out-of-pocket costs. And then finally, EPO stands for Exclusive Provider Organization Plan. As a member of an EPO, you can use the doctors and hospitals within the EPO network, but cannot go outside the network for care. And there are no out-of-network benefits. And here are some other basic terms to understand. The first one's a copay, and that's the fixed amount that you pay for a covered healthcare service, usually paid when you get the service. Most office visits or specialist visits have a fixed copay amount that you'll either pay in office or be billed for later. So it's good to get familiar with your copays for different services. For example, your policy might say $20 for office visits and $40 for specialists, and you'll be paying that amount whenever you go and visit those providers. A deductible is the amount that you have to pay each year before your health insurance plan begins to pay. For example, if your deductible is $1,000, your plan won't pay anything until you've paid $1,000 for covered services. So your first visit or visits up to $1,000 may all be out of your pocket. Coinsurance is usually the amount people are most often surprised about. Most insurance, even the best insurance, doesn't cover 100% of the cost of a visit. And so people will usually have a coinsurance, which is your share of the costs of a covered healthcare service, and it's usually calculated as a percentage. So if you paid your copay, but you're billed a random amount like $8.93 for a physical therapy visit that cost $89.30, that's probably a 10% coinsurance. So once you meet your deductible, you might still have a coinsurance on top of your copay. Also, it's very important to know whether or not certain procedures or services require pre-authorization. You may have to get your doctor to submit a prior authorization to your insurance company in order for service to be paid. So getting something pre-authorized, unfortunately, does not always mean that it will be ultimately covered, but not getting a pre-authorization when you need it can create administrative challenges. So it's always a good thing to have. Usually it's required for expensive procedures like MRIs. It's also important to understand what your limits are. And I'll use physical therapy again as an example. Some plans limit you to 20 physical therapy visits per year, while other plans allow you to have an unlimited number of visits, but you have to see your doctor every month for a prescription. So understand your plan rules about the services that you'll need before you get billed for these different services. So you have to play an active role in your healthcare delivery, including billing and payment. It's important to not be caught unaware of what your coverage is. If you read something that you don't understand, call customer service, take notes. Beyond just knowing what kind of plan you have and how much your deductible is, you might need to know what percentage of certain services are covered and who's in your network and whether they reimburse for out-of-network coverage. If you don't have the energy to do this, and I understand that most of us dealing with a cancer diagnosis don't, see if a friend or family member that you trust would be willing to do this for you. Okay, so we understand that we have to understand our coverage and read our policies, but where can you find that information? Your evidence of coverage or summary plan description can usually be found on your plan's website. If you have coverage through an employer, you can contact your Human Resources Department to get a copy of the contract if you don't have it. The terms of the policy is normally the first place to look in determining what's covered. There are many federal and state health insurance regulations regarding services that health plans must provide that would supersede those provided for an insurance contract, meaning there are protections that exist as to your rights, whether laid out in the plan or not. For example, coverage of pre-existing conditions and annual screenings without needing to pay a copay or deductible. Often, all this information is available online through your health insurance company's website. You can also call your insurance company to request a hard copy of your plan documents. If possible, it's best to access this information prior to a time when someone's in need of urgent care so that you at least know where and how to access it should an urgent medical question arise. So now that we know what kind of insurance we have and some of the basics about insurance generally and how to maximize that coverage, I want to talk a little bit about some of the rules about coverage, as well as some of the options that you have if you need to purchase new coverage. So just to clarify a few terms that refer to different types of private insurance, group is purchased by an employer and offered to eligible employees of the company and their eligible dependents. So an employer selects the plan or plans to offer to employees. And the premium cost is normally split between the employer and the employee. And there is a minimum percentage rate that the employer must contribute. For individual plans, you purchase those individually, obviously, for yourself or your family on your own or through the insurance marketplace created by the Affordable Care Act, and that's also known as Obamacare. These are often purchased with the guidance of an insurance agent to help navigate plan choices and premium costs. Insured is the more traditional way of providing employees with health coverage, where employers buy a health plan from a company and then the employer either pays a portion or the whole premium, and that's called a fully insured plan. Self-insured means an employer just opts to pay the employee's medical bills directly. This is more common in much larger companies, and often people don't know that their plan is self-insured because an employer might use an insurance company like Blue Shield as a third-party administrator. So figuring out whether you have a self-insured plan is important when it comes to your health insurance appeals. Grandfathered plans are plans that were created and purchased before the Affordable Care Act on March 23rd, 2010. They don't have to follow all these new rules, so check the date of when your plan was created. Some self-insured plans don't have to follow the ACA because they were created before it was implemented. And I just want to flag to you that if you're eligible for Medicare or Medicaid, you won't be eligible to purchase insurance through the insurance marketplace. And just to re-go over some vocab, Medicare is for those 65 and older, and enrollment normally begins within 3 months of your 65th birthday, or it's also for people who are under 65 but who've been receiving SSDI for 24 months, or for people that have end-stage renal disease. So you still become eligible for Medicare at 65, even if you have to wait until you're 66 or 67 to collect your Social Security retirement benefits. You do have to have worked long enough or have enough work credits paid into Medicare to be eligible for free Part A Medicare. But Medicare eligibility is not specifically tied to whether or not you are currently receiving retirement benefits. Traditional Medicaid is generally for those who meet categorical requirements, or age, blind, or disabled according to Social Security, and have limited resources, taking into account the things that you own, cash on hand, but excluding the home that you live in and the car that you use. We'll talk more about this in a little bit. If your income is less than Medicaid limits for your family size, you'll receive Medicaid at no cost. So Medicare has 4 parts. Part A and B are your hospital and doctor coverage, and Part D is coverage for prescription drugs. Medicare Part A helps cover inpatient care in hospitals and covers skilled nursing facility visits, hospice, and home health care. Medicare Part B helps cover doctor's services, outpatient care, and home health care. It also helps cover some preventive services to help maintain someone's health and keep certain illnesses from getting worse. And recent healthcare reforms have now added certain preventative services without copays. Part C is a health coverage option run by private insurance companies approved by and under contract with Medicare. And Part C has to cover all the services that original Medicare, which is Parts A and B, offers, but it can do so with different rules, costs, and restrictions that can affect how and when a patient receives care. Many pharmacy many Part C plans actually offer additional services, and these plans have a network of doctors, hospitals, and pharmacies to provide service only in certain geographic areas. So it's important to review the plan's cost and coverage before enrolling. When it comes time to shop for Medicare, you can explore the different options available to you on your own or with the help of your state health insurance assistance program, also known as SHIP office. A lot of people assume that when they become eligible for Medicare, they no longer have to pay for medical costs. And while many people depend on Medicare, it still only provides a portion of insurance costs. So how much does Medicare cost? Your tax returns are used to calculate Medicare costs, and it's based on your modified adjusted gross income, or MAGI. Part A is free for many people, so a person would only have to purchase Part A coverage if they're over 65 but have never paid into Social Security. This generally only applies to people who have no Social Security work history or insufficient work history, such as a stay-at-home parent. For people who pay a Part A premium, the 2019 Part A monthly premium is $437 a month if you paid Medicare taxes for less than 30 quarters, or $240 if you paid 30 to 39 quarters. The Part A Medicare inpatient deductible is $1,364 in 2019. The average 2019 Part B premium will be $135.50 for 2019 per month, and an annual deductible of $185 per year might apply to certain services. So people with high incomes over $85,000 individually, or $170,000 for married couples, have a higher Part B premium. And also people with limited incomes might be eligible for Medicare savings program for help with paying their Part B premium. An estimated 2 million Medicare beneficiaries, which is about 3.5%, will pay less than the full Part B standard monthly premium amount in 2019 due to the statutory hold harmless provision, which limits certain beneficiaries' increase in their Part B premium to no greater than the increase in their Social Security benefits. In a Part C plan, you generally must pay the Medicare Part B premium. Some Medicare Advantage plans may also charge you an additional premium. On average, those premiums will decline while plan choices and new benefits increase. And the average Medicare Advantage premiums in 2019 were expected to be $28. Costs vary by plan, but the average monthly premium for Medicare Part D is expected to be, that's D as in dog, is expected to be $32.50 in 2019. People with high incomes have a higher Part D premium, and the deductible varies by plan as well. For Part D, Medicare offers different levels of low-income subsidies called Extra Help, which can be applied for by submitting an application to Social Security. And these pay the cost of prescription drugs above and beyond a standard Part D prescription drug plan. So to qualify, you need to receive Medicare and have low income and assets. In 2018, a single person had to have less than $12,100.40 of annual income. So one of the reasons why we are doing this webinar at the time of year that we are is that Medicare's open enrollment period just began yesterday. So you can now go to medicare.gov to make changes to various aspects of your coverage. You can switch between original Medicare and Medicare Advantage depending on what works best for you. Even if you're satisfied with your plan, it's a good idea to look at what options are out there. And also, plans change from year to year, and so can your healthcare needs. So if there's a medication that you know that you're going to need to be taking in 2019, and perhaps it wasn't covered by your plan this year, now's a good time to research and see what type of plan would cover a certain treatment option that you might need, and make sure that you're prepared for that. And here are some other resources that we really think are good at the CLRC. We highly recommend both the Medicare Rights Center and your state health insurance assistance program. For additional Medicare resources, you can also contact our office through our intake line, and then also check your own state's requirements for the Health Insurance Premium Payment Program, or HIP. So like we discussed earlier, and this is again going to be put up on YouTube, so if you need that slide again or any more information, just let us know. Medicaid is a federal government provided insurance managed by the states for people with limited income, assets, and resources. Each state has its own Medicaid program, and it may be called different things in different states. For example, in Tennessee, it's called TennCare. In California, it's called Medi-Cal. There are two ways to qualify. Traditional Medicaid is generally for those who meet categorical requirements, and that meaning aged, blind, or disabled, and according to Social Security, and they have limited resources, taking into account the things that you own, cash accounts, etc. So it's important to check your state's rules about qualifying for traditional Medicaid. There may be different ways to qualify for free or share of cost Medicaid. If you don't meet Social Security's definition of disability or another category, but you are a low-income individual, age 19 to 64, there's a second option in some states. And before the Affordable Care Act, this didn't exist, but Medicaid was expanded to include a new category of eligibility so that more low-income people could receive health coverage. So if your income is up to 138 of the federal poverty level, which we'll go over, you can get Medicaid without that categorical disabled link. So perhaps you have a cancer diagnosis, but Social Security hasn't found you to be disabled, then you still might be able to get Medicaid through this. Obviously, as we've discussed in other webinars, it is likely as well that you might be considered disabled by Social Security, depending on your diagnosis as well as on your cancer diagnosis as well. So what if you can't get approved for Social Security, but you need health insurance and you have low income? So prior to the Affordable Care Act, you were out of luck. But now that 138 of the federal poverty level, which is an income of $16,460 per year or less, can help you qualify. States can choose to opt into this, and you can see the states that have adopted it and haven't. So you can contact so a lot of states, unfortunately, have not adopted Medicaid expansion. Some states like California have, fortunately. You can contact your state Medicaid agency or the CLRC, and we can tell you if expanded Medicaid is available in your state. Also, it's important to note that there are some states that make Medicaid available to people in certain circumstances, such as the Breast and Cervical Cancer Treatment Program in California, which extends the income requirement to 200% of the federal poverty level and provides no-cost Medi-Cal coverage for them. Or if a patient does not meet the federal poverty level guidelines, they may receive limited cancer treatment assistance for 18 to 24 months. And one thing that's important to note, if you are eligible for Medicaid, you don't need to wait for open enrollment to join. Okay, so here are the pieces put together. If someone earns more than 400% of the federal poverty level, and you can see that on the bottom line of the spreadsheet there, they can opt to purchase a plan either on or off the exchange through a private insurance company, and they can do whatever makes the most sense for them financially. If someone has an income that is between 100 and 400 of the federal poverty level, a buyer will likely qualify for premium tax credits, and they'll likely want to look on healthcare.gov or their state's marketplace website for insurance options. If someone's income is anything lower than 138 of the federal poverty level and their state has expanded Medicaid coverage, then they can qualify based solely on their income. And now you may have noticed that there is a coverage gap that exists as well. So if someone has an income of less than 100% of the federal poverty level in a state that hasn't expanded Medicaid coverage, then they won't qualify for tax credits on a marketplace health insurance plan, and they won't qualify for income-based Medicaid. So they'll have to look to their state's current rules, and they can try to qualify for disability-based Medicaid according to their categorical eligibility. And this ended up occurring because originally the Affordable Care Act required that states expand Medicaid. But in 2012, the Supreme Court struck down the Medicaid expansion requirement, and 19 states have not yet expanded their coverage, although Virginia and Maine are working towards expansion currently. In states that have not expanded Medicaid, eligibility is still based on pre-Affordable Care Act guidelines, and in most cases that means Medicaid's only available to people with disabilities, low-income children and pregnant women, and extremely low-income parents. So if you're looking to purchase insurance through your state's marketplace or healthcare.gov, we are getting to a critically important time of the year. It's really important to keep in mind that you can only purchase or change plans during open enrollment or if you're eligible for a special enrollment period. And for healthcare.gov, open enrollment is from November 1st to December 15th. Some states have their own private online marketplace, while others use healthcare.gov. So when you enter your information on healthcare.gov, if your state has its own marketplace, you'll be directed to that marketplace's website. And then as you can see, the states that don't use healthcare.gov have different timelines, but they're all starting around this time of year. Different timelines from just the healthcare.gov timeline. So one of the things that the current administration has already done to try to reduce enrollment is limiting the amount of time for open enrollment to 6 weeks. However, some states that run their own health insurance marketplaces have made changes to their open enrollment periods on their own. Another thing to keep in mind is that regardless of when your state's open enrollment period ends, if you want coverage for January 1st, you generally have to apply by December 15th. So it's a good idea to check with your state's marketplace as soon as possible to confirm your state's deadline for applying for coverage. So if someone misses these open enrollment periods, they'll either need to wait an entire year to enroll, or they'll need to qualify for a special enrollment period. And a special enrollment period is usually within 60 days of a qualifying event, such as getting married, losing insurance coverage, having a baby, turning 26 and getting kicked off your parents' plan, or moving. That's when a person can enroll in marketplace coverage. So plans in the health insurance marketplace are organized by metal categories: bronze, silver, gold, and platinum. And these categories are based on how you and your plan split the cost of your health care. And the quality of the care is the same. But for bronze plans, the insurance company pays 60% of the cost and you pay 40%. For platinum plans, the insurance company pays 90% and you pay 10%. It might be tempting to buy the cheapest plan, the one with the lowest monthly cost, but some of these plans with lower premiums end up costing you more in the long run if they have higher deductibles or higher out-of-pocket costs. So when you enter your income on the website, you'll learn whether there are tax credits to help you lower the cost of your insurance premiums each month. If you're below 400% of the federal poverty level, you may qualify for tax credits to lower that cost. However, there are many gaps that exist for making plans actually affordable for people, whether they receive tax credits or not. In addition to price, when you're shopping for plans, compare all the different insurance company plans. Depending on where you live, there may be many options or only a few in each category. If you like your doctors and providers, first check with those providers to see which marketplace plans they accept, and you might want to choose your plan based on the doctors that are in the network. An example is when our office had a Health Net plan, we had a slightly different network of doctors than we do now after we changed plans and moved to Blue Shield. So tax credits are now available for people under age 65 who purchase coverage on their own in a health insurance exchange and are not covered through their employer, Medicare or Medicaid. Premium tax credits will be available to help people pay for health insurance that will cap premiums on a sliding scale from 2% to 10% of their income. Tax credits are used when you enroll and are paid directly to the cost of your health plan to try to keep your costs down. You don't need to wait until you file a tax return at the end of the year. And that also means that after you sign up, you can't expect to be cashing out when your tax return check comes. Because all of these are just immediately applied when you buy the plan. Tax credits are only available through the exchanges, so you have to enroll on a health plan through your state's healthcare exchange or healthcare.gov if you want to use your tax credits. At the end of the year, the tax credits may be adjusted if your actual income is different than you anticipated. And this means that you'll want to notify your state's healthcare exchange or healthcare.gov if your income does change. It's always a good idea to look at your options off the exchange if you aren't eligible for financial assistance. For example, if you're on Medicare or if you earn more than 400% of the federal poverty level. Some plans might actually be less expensive off the exchange if you're not eligible for the tax credits. You can always go directly to a health insurance website or call a broker. So an analysis released by the Department of Health and Human Services shows that while the average premium is going up, the average subsidy to help defray that cost is going up even more. The average tax credit offered to people to cut the price of their insurance rose in 2018 to $555, and that's up 45% from the previous average credit of $382. So that means many people can take that larger tax credit and buy better insurance for less money. The Health and Human Services report shows that about 80% of people who buy insurance on the federal exchange could get a policy for $75 a month or less. In 2016, policies that cheap were available to only about 71% of enrollees. And so that's an increase of 9% of people accessing a lower cost policy, which is good. And many people who didn't qualify for subsidies in past years might get one for 2019 because the subsidies are based on two things: the federal poverty level and the insurance policy's sticker price, and both of these are going up. So if you're curious about what the process looks like to shop for an insurance policy, we can use Covered California briefly as an example. And these are the questions that they ask to determine your rates. The most challenging part of this can be entering in your household income, because you're supposed to anticipate what your income will be for next year, and that can be tough if you're contemplating leaving a job or if you're in and out of the workforce. There are also ways to search for doctors and facilities. However, these systems have improved over the years, but I strongly encourage you to call the doctor or hospital directly to confirm whether they accept a marketplace insurance plan. Many facilities have decided not to accept marketplace plans due to the lower reimbursement rates that they have. So don't just assume that because your doctor accepts an employer-sponsored Blue Shield or Kaiser plan that they'll also accept Blue Shield through Covered California. Please make sure that you ask. And then here's a few examples of some of the plans that were available in Los Angeles earlier this year. I know this sampling is very small, but you can compare some of the prices of these bronze plans. And here's an example of a Silver Blue Shield plan that was available in Los Angeles earlier this year. So you'll initially see that the premium, which includes any tax credits a buyer would receive, and it includes the deductible and primary care visits. If you click on Compare or View Detail, you'll get to see a lot more information about the plan. So you might be particularly interested to learn about the prescription drug benefits, so it's important to check the formulary of the plans that you're looking at if there are specific prescriptions that you need. So while our healthcare system was greatly reformed through the Affordable Care Act, and that was a great start, we still have a long way to go. There are still many people who fall through the cracks and can't afford coverage. Many people with an undocumented immigration status, or those who live in states that haven't expanded Medicaid, need to find other ways to get medical treatment. If you can't get healthcare during any of the ways that we've talked about, there are a few options that might be possible. One of them is called Hill Burden, and that is a congressional law which gave hospitals and other health facilities money for construction and modernization. So in return, these facilities that receive these funds agreed to provide a reasonable volume of service to persons unable to pay. While the program stopped providing funds in the late 1990s, certain healthcare facilities are still obligated to provide free or reduced cost care, and you can call the national hotline to get a list of obligated facilities. There's also a separate contact number for Maryland residents. Another one is charity care, and many hospitals have free or low-cost care available to low-income patients. You can speak with the social worker or the patient services at your local hospital department to determine which options might be available. Hospitals can't charge uninsured individuals who qualify for financial assistance more than what they charge insured patients, and this limitation on gross charges applies to all hospital care, not just emergency care. And then there's private health insurance. So although this can be an expensive option, anyone can purchase private health insurance as long as they do so directly from an insurance company or through an insurance broker. So now we're at part 3, ways to maintain or change coverage. And sometimes a phone call can result in a lot of savings, and other times a formal appeal needs to be made, but it all starts with knowing your plan. So now that we know what kind of insurance we have and some of the basics about insurance generally and how to maximize that coverage, I want to talk a little bit about some of the rules about coverage as well as some of the options that you have if you need to purchase new coverage. And we've covered marketplace insurance, Medicaid, and Medicare, so I'm going to briefly discuss COBRA and state COBRA. If you're employed or were recently employed, COBRA, which is the Consolidated Omnibus Reconciliation Act, allows you to continue on your employer insurance for a period of time even after you're no longer an employee. COBRA is a federal law that provides for continuation of coverage. Under COBRA, a former employee keeps the same insurance if they lose their job or drop below the number of hours required to get insurance through their job, or if they lose coverage that their spouse was providing by a divorce, legal separation, or death, or if they become entitled to Medicare. COBRA is expensive, but it may be the best option for people currently going through treatment. A patient can continue on the same insurance coverage that they had with their employer without having to switch doctors. So if someone feels strongly that they need to see their specific doctor for as long as possible, even if the cost is higher, then this could be a good option. One downside is that the purchaser has to pay the full premium, which is the portion that they were paying as an employee, plus the portion that their employer was paying, plus an administrative fee. And so that covers 102% of what their monthly premium cost is. An employee may qualify for COBRA if they work for an employer with 20 or more employees. The standard period of COBRA coverage is 18 months after leaving a job, but someone could potentially be eligible for an extension under certain circumstances, such as someone becomes disabled according to Social Security or has a second qualifying event. Most people know about COBRA, but many people don't know that some states have laws similar to COBRA that apply to employers with fewer than 20 employees or that extend the time period that a person may be eligible for continued coverage. For instance, in California, CalCOBRA applies to employers with 2 to 19 employees and lasts up to 18 months. For those working for an employer that has 20 or more employees, the law may extend regular COBRA coverage another 18 months, which would equal up to 36 months of coverage. CalCOBRA is more expensive, and during that time, the time that you're on CalCOBRA, you could be responsible for up to 110% of premiums. So if you're under 65, you may notice that there are certain gaps in the insurance system. The first is that a person is only eligible for Medicare if they are under 65 and have been receiving SSDI for 2 years. Therefore, a person under 65 who becomes disabled has a minimum period of 2 years before they can access Medicare. After receiving SSDI, a person who was previously eligible for Medicare may lose it due to the income that they're receiving from SSDI. And this creates a problem of figuring out how to get insurance while you may wait for Medicare to kick in. One option is to pay COBRA payments, but this is difficult because COBRA payments are typically expensive, while SSDI is likely only a fraction of a person's previous income while they were working. Some state programs exist, such as the Health Insurance Premium Payment Programs, or HIP that we talked about earlier, that will pay COBRA payments for a period of time. However, it's normally necessary to meet their eligibility requirements for Medicaid. If a person has limited assets and resources, they may be eligible for Medicaid still. However, as we just discussed, SSDI could make it so that they're pushed above those income limits. It's possible for people receiving SSDI but awaiting Medicare to purchase insurance on the Affordable Care Act insurance marketplace, and premium tax credits may be available to lower monthly insurance costs if a person's income falls within the guidelines. So in addition to these gaps, while awaiting Medicare to kick in, plans that might be required through insurance companies to supplement Medicare, such as Medigap plans or Medicare Advantage plans, are currently allowed to hike up prices on people that are under 65 because they believe that the costs for a person who's disabled may exceed the cost for an average person reaching age 65. So it's a struggle just to get to that Medicare point for someone that's under 65, and then once they get there, they can expect a price hike on the Medigap and Medicare Advantage plans. Now we're going to talk about consumer protections. Unfortunately, we don't have I wish that we had a good answer for that problem currently. We're going to talk about some other protections that exist and help people with other gaps in the system. So under the Affordable Care Act, which passed in March of 2010 and was fully implemented in 2014, a lot of changes took place, and one of those being that insurance plans that count as minimum essential coverage can no longer discriminate against anyone with a pre-existing condition or genetic predisposition, including cancer. That means that when a person living with cancer needs to get new coverage, they don't have to worry about whether they'll be denied insurance or charged more for insurance based on pre-existing condition unless a plan has been grandfathered in. The pre-existing condition rule is true for health insurance. It's not, it doesn't apply to life insurance, disability insurance, or long-term care insurance. Some states offer protections for people with pre-existing conditions who want to obtain these types of insurances, but they're out of the scope of this webinar. For health insurance, you can't be discriminated against because of a pre-existing condition. So for anyone with cancer or positive genetic test for predisposition to cancer, you can still buy COBRA, marketplace insurance, and get Medicaid regardless of your health history. Your age and where you live are the only personal characteristics that can be used to set rates. This change is significant because before 2014, gender was a determining factor in establishing premium rates, and women were being charged a higher rate than men typically. And now, fortunately, gender cannot be a determining factor in setting those premium rates. Some states allow insurance companies to charge tobacco smokers more than non-smokers, up to 50% more, but not all plans do this. The rating area is an area used for determining premium rates, usually a zip code. The premium is based on the average healthcare costs and physician or hospital discounts in that area. So costs might be higher if you live in a metropolitan city rather than in a small town. So although we hoped that the Affordable Care Act repeal efforts had ended this summer with the late Senator John McCain's iconic thumbs down vote, Republicans made one last push with an Affordable Care Act repeal bill in September, and the Senate faced a deadline of September 30th to pass the legislation with a simple majority allowed under the budget reconciliation rules. Normally the Senate requires a 60-vote majority to pass any legislation. That's a high bar that makes it hard for the Senate to quickly pass major pieces of legislation. But thankfully, this bill also failed. So the Affordable Care Act consumer protection still exists. Preventive services still have to be covered by insurance plans. Young adults can stay on their parents' plans through age 26. Health insurance plans cannot impose lifetime limits and cannot discriminate against people with pre-existing conditions. But one major change is that the individual mandate penalty will be ending soon. So in late December 2017, Congress successfully passed the Tax Cuts and Jobs Act, repealing the penalty for the individual mandate. This required that individuals have insurance or risk paying a penalty unless they qualified for an exemption to the rule or had a short 2-month gap in coverage. And while it initially sounds great that a tax penalty was repealed, the reality is that insurance companies will likely increase their costs for people that need medical care because the penalty helped bring healthy people into the marketplace to lower health costs for everyone and helped fund the implementation of the Affordable Care Act. So effective in 2019, you'll still be required or mandated to have insurance because the mandate itself was not repealed. However, you won't have to pay a fee if you don't comply. So that's the penalty part. Additionally, you must still report that you had credible creditable minimal essential coverage to the IRS or request an exemption. And you're still responsible for having insurance for the 2018 tax filing season or risk a penalty. So that's for the 2018 tax filing season. So this hasn't quite kicked in yet. So you still need to have insurance for 2018. Otherwise, there's a penalty of either $695 for an adult or 2.5% of household income, whichever is higher. So some insurers are returning to exchanges after being out of the marketplace the last few years, such as Anthem expanding in Kentucky and Virginia, and Oscar entering Florida, Arizona, and Michigan. It's expected that a little more than 1/3 of counties will have more insurers than last year, according to the Robert Wood Johnson Foundation. For 2019, the Trump administration is making it easier to buy alternative policies that will be less expensive but won't provide the same benefits, especially for people with pre-existing conditions. Also, there's some uncertainty following the recent changes in the Supreme Court and several states bringing challenges to major portions of the Affordable Care Act. This year, there are still some double-digit price increases. However, it's expected to be the exception rather than the norm. According to Consumer Reports, the 2019 average monthly premium for each state based on the second lowest cost silver plan for a 40-year-old non-smoker who doesn't receive subsidies ranges between $300 and $900 per month, depending on what state that they live in. In 2018, the average annual premium for family coverage rose 5% to $19,616 per year, and that's up from 2017's rate of $18,764. Unfortunately, the administration decided to stop paying cost-sharing reduction subsidies, which were used by health insurance plans to subsidize co-payments and deductibles for low-income health plan enrollees. And when the Trump administration made this decision, insurance plans responded by raising their premiums. And they sort of figured out that if one source of income was going away, then they reasoned that they needed to find another. This turned many single-digit rate hikes into double-digit rate hikes. Insurance plans added 7 to 38 percentage point rate hikes to respond to that last of cost-sharing reduction subsidies for 2018. In some places, though, rates have skyrocketed and increased by 75% or more. So I want to talk about some ways to optimize health insurance. Patients can check with their insurance companies to see if they offer a case manager. Case managers can be your go-to person for information about your plan, and they'll often even go through appeals or advocate on your behalf to gain coverage or reduce costs. So if your plan doesn't offer case managers or patient navigators, ask to speak with the same person each time you call within a certain department, and if possible, write down their last name or employee number and extension. It's helpful to keep one contact for each department and try to make friends with them, because some positive rapport can go a long way towards saving a lot of money if they spend time finding ways to reduce your costs. That's also a way to reduce some of the energy that you have to put into trying to advocate for yourself. You can also avoid having to re-explain your entire story every time that you call. Keeping track of who your contact is will assist with keeping accurate records. That's also very important. Also, keeping careful notes of each phone call, including the date and time, the names of contacts, the information covered, and the authorization numbers. Any written communications, including copies of bills, explanation of benefits, check stubs, or anything else like that, are very important to keep a track of. They're really helpful for appeals. Also, maintaining an accurate journal or a binder of notes will lend credibility to you if there's ever a discrepancy. So while this is a lot of work, filing systems are helpful to assist with keeping track, and it might be helpful to use a notebook to contain information. Even just if you aren't an organized person, even just having an area, a folder where you always put a bill into is really important. But the more organized you can be and the easier it is to find things quickly, you're going to be saving yourselves a headache in the long run. Pre-authorization, which we briefly discussed earlier, is a decision by your health insurer that a healthcare service or prescription drug is medically necessary. It doesn't mean that it'll always be authorized. So if you have to get prior authorization, ask them to send you a written copy of the prior authorization. One of our staff members had a claim denied for not having gotten prior authorization, but they actually had a paper copy of it. And because they'd gotten that, all they had to do was send it over to the insurance company, and that straightened everything out. They do make mistakes, so that's important to always stay on top of the information that you have and double check the things that you receive. This should go without saying, but open all your medical mail, even if it seems daunting. If you're opening your mail, you've taken the first step to understanding what you're up against. So sometimes there's no way to appeal decisions if you've waited too long, so it's important to check for mistakes early. Review all your medical bills because mistakes do happen, and sometimes a simple phone call can help. We have a handout on our website with some information about medical billing, and I think we recently had a webinar on that in May that was posted that might be accessible on our YouTube. So just like with your overall insurance plan, it's a good idea to become familiar with your prescription drug benefits. Medications must first be approved by the Food and Drug Administration, or FDA. Until a drug is approved, it can't legally be given to anyone except through an approved clinical trial or a manufacturer's compassionate use program approved by the FDA. Compassionate use programs allow a manufacturer to give certain individuals medication that is being tested in clinical trials before the FDA has made a decision about approving or not approving the drug. When the FDA approves a drug, it is approved for certain conditions or indications on the label. Regardless of what the label says, though, a physician can legally prescribe an FDA-approved drug for any reason. This is called prescribing the drug off-label. And it's important to note that your insurance company might not approve coverage when something's prescribed off-label, though. Each plan has a formulary or list of approved medications. Formulary medications can usually be prescribed without pre-authorization. The insurance company, not your physician, decides what's in their formulary. If your provider prescribes a non-formulary medication, check to see if there's a formulary equivalent. If not, talk with your healthcare provider about requesting special formulary coverage from your insurance company. Some insurance companies require step therapy, which is the practice of beginning drug therapy for a medical condition with the most cost-effective and safest drug potentially, and progressing to other more costly or risky therapy only if necessary. It's important to work with your doctor on appeals to discuss why the prescribed medication provides the patient with the best possible outcome. Finally, if an insurance company is repeatedly issuing outrageous refusals to provide medication, some desperate patients have taken to social media, including Twitter and Facebook, and enlisted their friends to publicly demand coverage, often with effective results. So you may have noticed that there are some serious gaps in the ability to access affordable and quality insurance programs in this country. Please make sure that you vote for people that are willing to expand access to insurance programs and improve coverage options. And Election Day is coming up soon on November 6th. We also have some helpful resources on our website, including a step-by-step guide to insurance appeals and a handout with information about accessing prescription drugs. But here are some other related areas for accessing insurance-related resources that we really like. The Patient Advocate Foundation is really excellent, and so accessing that website is something that I would highly recommend. I think I'm going to leave it on this page for folks to be able to write down these resources for a minute, but we've reached the end of our presentation. So thank you so much for your attention. If you have any general questions about today's presentation or need some clarification, you can type that in the chat box. I'm going to move the slides along just so that people have this information. You can always fill out an intake at clrcintake.org if you have any specific questions. So please feel free to do that, and we will make sure that we answer that. Also, if I am not able to get to any questions that you have, looks like we only have a couple minutes here, you can just ask your question on our website as well, and we will be sure to answer it for you. Okay, and I'm going to stop the recording now, and then folks can stay on if they'd like, and otherwise I will try to take some questions here.